Hey everyone, welcome to this high-yield clinical explainer. Today, we're totally demystifying coagulation modifiers so you can absolutely crush the NCLEX. If you've ever felt, a little overwhelmed by the whole clotting cascade or bleeding precautions, well, you are definitely in the right place. We're going to uncover exactly what you need to know to keep your patients safe. Okay, so here's our roadmap for today. 1. Heparin and LMWH mastery. 2. Warfarin and bridge therapy. 3. DOACs, which are target-specific inhibitors. And 4. Antiplatelets and bleeding risks. Let's jump right in. Now, when tissue trauma happens, the extrinsic pathway activates kind of like a blaring emergency alarm. And as you can see here, warfarin steps right into the mix and basically cuts off the supply chain. It inhibits the liver from synthesizing those crucial vitamin K-dependent clotting factors, specifically factors 2, 7, 9, and 10. And without those building blocks, a stable clot simply can't form. On the flip side, the intrinsic pathway is triggered by internal blood trauma. And this is exactly where heparin works its magic. By binding to antithrombin 3, heparin acts like a super fast off switch, instantly shutting down thrombin and activated factor 10 to just completely halt the coagulation cascade in its tracks. All right, section 1, heparin and LMWH mastery, turning off the coagulation cascade. So the absolute crucial point here is this non-negotiable NCLEX triad. Seriously, memorize this. If your patient is on an IV heparin drip, you are religiously checking their APTT, which is the activated partial thromboplastin time. You really want that value to be hanging out right around 1.5 to 2.5 times the normal control value. And if things go south and the patient bleeds too much, you absolutely must have the antidote ready to go, which is protamine sulfate. Now, when you're actually administering subcutaneous heparin or low molecular weight heparins like enoxaparin, you gotta follow these exact physical nursing actions. You inject it right into the subcutaneous fatty area of the abdomen, specifically the love handles. Seriously, they're literally lifesavers here. Make sure you stay at least 5 centimeters away from the umbilicus. Oh, and for enoxaparin, keep that little air bubble in the syringe. It actually helps lock the medication in. And whatever you do, please do not massage the site afterwards, unless you want to cause some massive, incredibly painful hematomas. All right, boot camp quiz time. Let's test your active recall. Number 1, how do you recognize HIT? Well, you look for a paradoxical drop in platelets alongside new clots, and if you see that, you stop the drug immediately. 2, what about the enoxaparin air bubble? You just leave it right in there. 3, what's the preferred anticoagulant for pregnancy? That would be heparin, because it doesn't cross the placenta. Number 4, what is that therapeutic APTT target again? It's 1.5 to 2.5 times the control. And 5, if you suspect IV infiltration during a heparin infusion, what's your first move? You remove the lock immediately and replace it at a totally new site. Moving right along to section 2, warfarin and bridge therapy, the vitamin K antagonist. Okay, so for warfarin, your golden metric is the INR, or the International Normalized Ratio. I want you to think of it kind of like the speed limit for blood clotting. You want to cruise safely between 2.0 and 3.0. Now, if the INR spikes way too high and the patient starts bleeding, your direct antidote is vitamin K. That's going to allow the liver to start synthesizing those clotting factors all over again. Now, this comparison table is absolute gold for your exams. It's actually fascinating how stark the contrasts are here. Heparin is super fast-acting, but warfarin takes a good 3 to 5 days to reach a steady state. Heparin uses APTT, whereas warfarin uses INR. Heparin's antidote is protamine sulfate, and warfarin's is vitamin K. And crucially, like we mentioned, heparin is the drug of choice for pregnant patients, while warfarin is strictly contraindicated because it definitely crosses the placenta. So here is a classic trick question, and it involves diet. Patients on warfarin should not entirely eliminate leafy green vegetables from their diet. Actually, it's the opposite. They need to maintain strict dietary consistency. If they suddenly eat massive amounts of spinach one day, their INR is going to drop, which risks a clot. But if they stop eating greens entirely, their INR might spike, risking a bleed. So consistency is totally the key here. Okay, so why do we call it a bridge? Well, because warfarin takes up to 5 whole days to build a sturdy defense, we use heparin, or enoxaparin, to bridge that dangerous gap in the meantime. We start them both simultaneously. The heparin keeps the patient safe from clots right now. And then, once the warfarin INR hits that therapeutic range and is stable for 24 hours, the bridge has done its job, and we can discontinue the heparin. Let's hit 5 critical thinking questions for warfarin. Number 1, why do we bridge? Because warfarin takes 4 to 5 days to reach steady state. 2, what happens if a patient suddenly stops eating kale? Their INR will likely shoot up, raising their bleeding risk. 3, is warfarin safe postpartum? Yes, it's contraindicated during pregnancy, but it is safe postpartum. 4. What happens if you add amiodarone to warfarin? This is wild. It leads to a 50% increase in INR, meaning the warfarin dose actually has to be cut in half. And 5. What is the risk after giving vitamin K for an overdose? You'll see warfarin resistance for up to 7 days. All right, mid-explainer checkpoint. Before we tackle the newer medications, I really want to make sure you're getting immense value out of this. Hit that like button and subscribe to the Nurse Crush It YouTube channel right now so we can keep making these high-yield explainers for you.
Okay, Section 3, DOACs, or novel oral anticoagulants.
Do you notice a pattern here on this table? Drugs with an X in the name, like rivaroxaban and apixaban, selectively ban factor XA. I mean, it's literally right there in the name. Meanwhile, dabigatran goes straight for thrombin, or factor 2A. Knowing the exact factor they inhibit is going to earn you some super easy points on exam day. Now, this is a fascinating yet highly specific NCLEX safety rule. Dabigatran absolutely hates moisture. It has to be kept in its original moisture-sensitive bottle and used within 4 months of opening it. If you take a capsule out and put it in one of those daily Sunday through Saturday pill sorters, it literally destroys its efficacy. So no pill boxes for dabigatran.
Time for some DUAC active recall. 1. How is dabigatran stored? In its original bottle to protect it from moisture. 2. Do DOACs require routine INR or APT monitoring? Nope. And honestly, that is their major advantage. 3. What is the exact mechanism of rivaroxaban? It is a selective factor XA inhibitor. Number 4, can a patient use a pill box for dabigatran? Absolutely not. And 5, how do the routes differ? Well, DOACs are administered orally, unlike heparin or enoxaparin, which are given subcutaneously or IV.
And finally, Section 4, antiplatelets and bleeding risks. The absolutely crucial point for patient safety with antiplatelets is aggressively monitoring for severe thrombocytopenia. If you see the platelet count drop below 80 times 10 to the 9th, you must notify the provider immediately. Furthermore, because these drugs severely impair clotting, there's a really strict rule that you have to stop antiplatelet therapy 5 to 7 days before any invasive surgery or dental procedure. Okay, here is a massive safety alert. While aspirin is an amazing lifesaver for adults at risk of a myocardial infarction or a stroke, it has a deadly pediatric contraindication. Giving aspirin to children or adolescents, especially during a viral illness, can trigger a totally fatal neurological condition called Ray's syndrome. So, bottom line, never use aspirin for pediatric fevers. All right, let's wrap this up with our final 5 hard questions. Keep that energy high. Number 1, what's the pre-op rule for antiplatelets? You stop them 5 to 7 days before surgery. 2, can you give a child aspirin for a fever? Never, because of the risk of Ray's syndrome. 3, at what platelet count do you need to immediately notify the provider? When it's less than 80 times 10 to the 9th. 4, how exactly does clopidogrel work? It interferes with platelet function and aggregation. And 5, what are the early signs of internal bleeding? You want to look for unexplained restlessness, changes in their level of consciousness, an increasing heart rate, and a dropping blood pressure. So, I want to leave you with a scenario to think critically about. If a patient on warfarin develops a massive pulmonary embolism, do we just push more warfarin, or is it time for a completely different coagulation modifier? Remember, warfarin prevents new clots, but it does absolutely nothing to lyse an existing massive clot in the lungs. So, would you need a thrombolytic here, or maybe an IV heparin drip? Keep reviewing your pathways, stay focused on those safety priorities, and I will see you in the next explainer to uncover the answer.